Well, the theme this time is a little different than what we've had before, and we're going to focus on valve disease and the way the International Heart Institute deals with valve disease, and you're going to hear from some surgeons along the way. Our first speaker is Dr. Joe Knapp, and Joe is an old friend. He's been associated with this program for many years, though he was away for a few years and returned about a year and a half ago, and would have been reintroduced last year were it not for a telephone or an airplane connection that he missed. But we will reintroduce him this year. Joe is interested in imaging and is a general cardiologist and a quality physician and a friend. Joe Knapp.
What you're going to hear is a series of talks today, and you've probably gotten the brochure that outlines it, but to kind of put it in some perspective, the first two talks, we're going to tell you a bit about what heart valve disease is all about, those of us who take care of patients who have valvular heart disease. And then the last half of the morning is going to be a combination of the surgeons who repair and replace heart valves when they're diseased or damaged, and the folks after the heart valve surgery is completed who help folks who have had valvular heart conditions return back to their normal life. And so that's really what we're going to be doing this morning. Now, what I'm going to do is, this is like the old-time movies. I remember when I was a kid, we used to go to the movies, and the first thing you always hoped for was there were going to be some cartoons. So I'm going to show you some cartoons here in a second. Okay, but first of all, I want to talk to you, and then you're going to see the main feature, which is Dr. Rich Gula, and then you'll hear the guys who really know what they're talking about. What I'm going to tell you here is we're going to go over some just very basics, and if you all know this, please, my apologies, but for many of you, I think this will hopefully be kind of an introduction to what valvular heart disease is all about. If you think about your heart, it's a pump. Its design and purpose is to pump blood around your body. It really has four main functional features. It has muscle that pumps. It has valves, and these valves are what we'll focus on today, but the valves in the heart have a purpose of keeping the blood going in the right direction, not the wrong direction. There are arteries that feed the heart, and this is what we focused on most of the time in the past, because it is really the main cardiac problem that we in first world countries deal with, which is coronary artery disease, as opposed to third world countries where valvular heart disease, what we're going to be talking about here, is really much more prominent. And then there's an electronics of the heart as well. So if you think about the heart, if you're in any kind of industry, if you're in construction at all, we're not much different than the construction industry. We have plumbers, we have electricians, we have, if you wish, sheet wall or sheetrock, dry rock hangers. We basically are in the human construction business when it comes to the heart. The heart valves are one-way valves. They have a purpose of keeping the blood going in the right direction, not the wrong direction. The heart really is two pumps. It's not one pump. There's a part of the heart that will take the blood that is in your body and pump it into your lungs where it can get blood, or where it can get oxygen. And then there's that part of the blood is returned to the other side of the heart, which returns the blood to the body. So there's really two pumps that are side by side. On each side of the heart, there are two valves. There's an entry valve that lets the blood get into the pump, and there's an exit valve that lets the blood get out of the pump. So realistically, we're talking about a two-cycle engine, two pumps, side by side, with inlet valves and outlet valves. And that's the basics of what the function is that we're going to be talking about today. Now, you will find that over 90% of the heart valve problems that we deal with in adult cardiology are on the left side of the heart, the part of the heart that pumps blood to the body. And I won't get into all the details of why that's the case, but it really is the case that for 95% of folks who have heart valve conditions that we deal with, they are on the left side of the heart, the main part of the heart that pumps blood to the body. Valves generally malfunction in one of two ways. They get stuck and don't open, or they don't close and they leak. And when we talk about leak, we talk about a back leak. Blood does not leak out of the heart, it just leaks back from where it came from, which is an inefficient pump. If you have a pump that is not moving the blood efficiently, it isn't functioning as well as it should. And that's realistically what we're dealing with here with valve disease. Now, if you look at the heart, this is, oh, by the way, the slides that you're going to see here come from 3 primary website sources, and you can reach them on the internet. One is the Cleveland Clinic, one is Mayo Clinic, and one is the Texas Heart Institute. And any of you who are interested in some really nice didactic information that is patient-friendly, those 3 websites have terrific information about valvular heart disease. If you look at the heart, and this is just opening it up in cross-section, here we are talking about the 2 sides of the heart. And as cardiologists are wont, the left side of the screen is the right heart, and the right side of the screen is the left heart. Go figure. The names are not necessarily important at this point. We'll get into them a little later. Again, I told you cartoons. When the heart is relaxed and not pumping, the blood is not pumping, the blood comes into the heart across these inlet valves into the main pumping chamber. This is the tricuspid valve, which is on the right side of the heart, the mitral valve, which is on the left side of the heart. The blood comes across the valve into the main pumping chamber. As the heart then begins to pump, these valves passively, meaning they just flop closed, seal shut. As you can see here and here, they just seal shut. At the same time, when the heart is relaxed and beginning to fill with blood, these exit valves here and here are passively shut. They just literally close. And when the heart pumps, these valves passively open up. So there's no mechanics, if you wish, or energy work of the valves moving. They really are passive structures. They just open and close in response to the pumping actions of the heart. So the heart rhythm plays a role in how valves, if you wish, function. Again, we're going to focus predominantly on this left side over here of the heart. On a more detailed view, an anatomic view, this is, again, an inlet valve here, an inlet valve, an outlet valve here, and an outlet valve here. Now, as I mentioned to you, when the valves open, they do open passively, and they do close passively. The kinds of things that can go wrong with the heart are really fairly, there's 3 or 4 main ways that valves go bad. One way is you can be born with a bad valve. And there are a series of kinds of valve illnesses or conditions that are basically conditions that people are born with. One is called a bicuspid aortic valve, which is a 2-leaflet valve. And then the mitral valve can have basically what amounts to birth defects that may not be present at birth, but develop over time. Valves can degenerate as well. They can just basically break down from wear and tear. Just the way the valves in your car can break down, the valves in the heart can break down. The most common by far in our society is a condition called aortic stenosis, or a narrowing of the aortic valve. But valves can also leak as well as a result of just wear and tear, and we'll show you a lot of that here over time. Valves can become injured by infection conditions or various inflammatory conditions. Not so much now in first world countries, but still in third world countries. The most common inflammatory condition is rheumatic fever, which can damage valves. When I was in my training at the University of Arizona in the late 70s and early 80s, we took care of all of the Navajo and Hopi Indian populations of Arizona and northern New Mexico. And I can recall that the first clinics I did on the Navajo and Hopi Indian reservations in cardiology, we were there for a good 2 weeks. I saw, in my first 2 weeks of clinic there, I saw 156 patients. 153 of them who had cardiac disease had rheumatic valvular heart disease. It is a condition that's very common in third world countries and still remains common in third world countries. It is fairly uncommon in our world due to some of the antibiotic exposures that we all have and the treatments that we now have. But it still remains an issue, and we still do see rheumatic heart disease. You can develop actual bacterial or infective damage to heart valves, which is direct infections on heart valves. So if you wish, this is a third way that valves can be injured. They can be actually traumatized by inflammatory or infectious conditions. And then there's a whole host of other things that aren't really valve damage per se, but because the heart valve doesn't live in isolation, it's part of the heart. If other parts of the heart are damaged or injured, they can make the valves malfunction. And not uncommonly, when folks have heart attacks, which damage the heart muscle, not the heart valve, the valves become malfunctioning because the valves need the heart muscle to function normally for the valves to work normally. So this is just a series of kinds of conditions that can actually cause a heart valve to not work right. You can be born with a problem, it can be developmental just from an aging condition, it can be inflamed upon, or there are other conditions of the heart that can actually lead to the valves, which themselves are normal, to malfunction. So we're going to walk you through a couple of these different, again, cartoon slides. The first thing we talked about was aortic stenosis, the narrowing of the heart valve. If you look here and you compare these two, the aortic valve is the outflow valve on this side of the heart. It's a 3-leaflet valve. You can see these 3 what we call cusps on the valve here. This is the pulmonic valve, and this is with the heart pumping. And as you can see, this pulmonic valve here has opened up to let the blood get out of the heart. The aortic valve here is not opening up. It's a small opening here, this little black opening here, as opposed to here where you've got a good, nice, large opening of the heart. This valve opens so the blood can get out normally. This valve does not open up, which means the heart has to work harder to pump the blood across that narrowed heart valve. This is a very, very common condition, especially in folks in their 7th and 8th decades of life. A lot of folks present with this condition called aortic stenosis. It puts a lot of stress and strain, makes the heart work harder, and eventually the heart muscle can fail if that valve is not dealt with. Honest to God, there's really no medical treatment for this. This is a surgical condition. It has to be surgically fixed at this present time. We don't have any medical treatments to deal with this. If you look at, again, at a picture of the aortic valve and you look at it from looking down on it, the aortic valve has 3 separate leaflets that are supposed to open. Here again is that aortic valve looking at it from the side. It should open up normally. If it doesn't open up normally, you will have a slit of an opening as opposed to a wide opening in the valve, and that causes difficulty with getting the blood out. This is what an aortic valve, if you were to stand over it and look at it, would look like. It has these 3 what we call cusps that are basically like small buckets that will flop open and then close as the heart relaxes to allow the blood to get out of the main pumping chamber or left ventricle. When the normal aortic valve opens, it opens to look like this, kind of a triangulated opening and a fairly wide open for the blood to get out of. If it's scarred, those leaflets won't separate and let the blood get out as well, and it'll start to look like this. And these openings, which normally are about between the size of about the size of a quarter, can narrow down to, gosh, we've seen them down to the point of not much bigger than really a pencil lead opening. And you can think about how much, if you have to pump all the blood out through an opening that's 1/10 or 1/20th of the size that it should be, that's a lot of wear and tear and stress and strain upon the heart muscle. One of the more common congenital conditions, and I mentioned that at the start, is sometimes folks are born not with 3 of these leaflets on the aortic valve, but can actually be born with just 2. And it'll look like this. Rather than 1, you'll have 2 of these leaflets. This is, from a blood flow characteristic standpoint, not very efficient. This kind of a valve will generally wear out after about 50 or 55 years, become scarred, not open up well, and then again start to put significant strain upon the heart muscle, so the heart muscle just can't pump as well as it should. Valves can not only get stuck where they don't open, but if they don't close tight, the blood that's been pumped out will back leak into the pumping chamber of the heart. And in this particular case, if you look at this aortic valve here, you can see that when the leaflets should be coming together, they're not sealing, and you see this crevice or separation between the edges of the leaflet here, so the blood can go backwards into the pumping chamber. And so in essence, what's happening when you have a leaky valve is blood is going back and forth and back and forth and back and forth across the heart valve. The blood that should be going out to your body, it can't do that. A goodly portion of it's going back and forth. That's very inefficient and very wearing and tearing and taxing upon the heart, and will eventually cause the heart muscle to wear out. Now, this is an important concept to keep in mind. What really concerns us about heart valve disease isn't the heart valve disease itself. It's the effect that the heart valve disease has upon the function of the heart. The end game in all of this is keeping the heart muscle, which is a pump, pumping effectively. Over time, if the heart has to squeeze with too much pressure to pump the blood out across a narrowed valve, or has too much blood that it's pumping back and forth because of a leaky valve, that muscle is going to wear out. So the valve itself is not the issue. The issue really comes down to the wear and tear that that leaky or narrowed valve has upon the heart muscle and the wear and tear that eventually will occur. We want to prevent that. That's the whole end game here, is preventing the wear and tear on the heart muscle. Now, the mitral valve, which is the inlet valve into the left side of the heart, which you look at here, is a round orifice, but really is a 2-leaflet valve rather than a 3-leaflet valve. As I mentioned before, most adults have 3-leaflet aortic valves. Virtually all adults have 2-leaflet mitral valves. It's very uncommon for folks to have, extremely uncommon to have mitral valves that have other than 2 leaflets. And the leaflets of the mitral valve are kind of interesting, and the best way I can describe it is if you look at a mitral valve, it's 2 leaflets, one leaflet shaped like a horseshoe and the other like a toilet seat. And the leaflets, when the valve opens, open like yay, and when it closes, close like yay as well. So it's a functional, basically toilet seat and horseshoe coming together to open and close and let the blood get in and out of your heart. Just like with the aortic valve, the mitral valve can get stuck or stenotic, or it can get leaky and blood can go back and forth, putting stress and strain on the heart. What you see here is what generally looks like a fairly normal mitral valve. Now, what's different between the mitral valve and the aortic valve is you see these things that are attached to it down here. The mitral valve, if you think about heart valves should function like a set of French doors. They should open to let the blood go where it's supposed to and seal shut so that the blood doesn't go back where it came from. That's the way valves should work. Most leaky valves, rather than acting like a set of French doors, act like a set of barroom doors. They'll open, and then rather than sealing shut, in some fashion or other, they'll flip and not seal. And so you're left with an opening in both directions. We want valves to open in one direction, not in both directions. And when they open in both directions, they leak. And that's really the most common problem that we see. And especially with mitral valve, that's the most common problem that we see, is a valve that functions like a set of barroom doors rather than French doors. If you look on end, and this is looking rather than down at the valve itself, here we're looking at the valve itself. If you're looking at the side of the valve, this is the entry chamber which accepts the blood into the heart. Here's the pumping chamber of the heart. Here's the mitral valve sitting here. Again, it's a 2-leaflet valve, and for simplicity, these 2 leaflets look the same, but they're clearly not in the real condition. Like say, one is toilet seat, one's horseshoe. All these strands and structures here are the supporting apparatus that prevents that valve from acting like a set of barroom doors. These are the struts that keep it acting more like a set of French doors. And when the valve closes, it should close in a fairly flat situation like that, with the leaflets coming together so that the blood, when this chamber pumps, doesn't go backward, it goes out the heart, out to the body like it should. Now again, just like the aortic valve can get stuck, the mitral valve can get stuck too. This represents the blood coming into the heart, and here you can see these leaflets are kind of cartoon pictured as if they're thickened, not moving real well, and not separating. It's like a stuck door, and that's exactly what it is a stuck door where the blood can't get into the main pumping chamber. And that causes a lot of problems with back pressure and blood not getting into the heart and the heart not functioning well. The most common cause of this is rheumatic fever. We don't see that very often anymore, but we still do, even in our populations. Again, it's much more common in third world countries. So just like the aortic valve can get stuck, the mitral valve can get stuck. If you look down, this is looking at the mitral valve here. This is when the valve is open. You can see that there's a nice big, in a sense, quarter-sized or more opening in the valve. When the valve is narrowed, rather than having a quarter-sized opening, you have a very slit-like or small opening here. And again, it's a matter of how much room there is for the blood to move from one part of the heart to the other. And in a stenotic valve, it's going to be a lot smaller. This is the tricuspid valve, which is on the right side of the heart, the other side of the heart, which shows you that in this case, these two are fairly similar. Not uncharacteristically in folks, oftentimes we'll see disease of one valve and every other valve in the heart is perfectly fine. A lot of it's related to chance, some of it's related to what causes the valve to malfunction in the first place. Valves can not only get stuck, but again, they can leak. And again, if the heart is pumping and these valve leaflets can't seal tight for one reason or another, they're going to leak and blood's going to go backward where it came from. And again, that's a very inefficient pump. There's a term which is used in the lay, we use it a lot, but you hear a lot of it in the lay public too, of a condition called mitral valve prolapse. It does exist, it is real, it is there. What it amounts to is a leaflet that works, one leaflet or the other, or sometimes both, really does act like a set of barroom doors. One leaflet pops back and stays the way it's supposed to. The other leaflet is sprung and will flip back and forth and back and forth. Where these two don't come together, it leaves a hole, and where that hole is, blood can go backward from where it came from. Mitral valve prolapse is a condition that we get concerned about when it causes significant leak across a valve. If you look here, this is what a normal mitral valve would look like. These are the cords that support it so that it doesn't flip back. When either these cords here that support the valve are long, or the valve leaflet itself is long or malpositioned, you'll have this gap or opening where blood can go backward from where it came from rather than forward out the aorta to your body. And that's a pretty common condition that our heart surgeons work on as far as repair surgery. I mentioned that valves can be damaged as well, and occasionally these cords or these muscles down here can become torn or disrupted. And just like a parachute that has had some of the parachute cords torn, or it's going to flop and flail, and that's exactly what we call this. It's a flail mitral valve leaflet, and this will flutter in the breeze and not seal correctly, and blood will go backwards. So that's basically what valves do and look like and how they can go wrong, and it's really a fairly simple process. I mean, it's one or the other. It's either it's one of three things. They either work normally, they get stuck, or they get leaky. But it's really what's causing it that is important for us, and for us, it's important because then we can then advise our surgeons how best to fix these things when they do need to be fixed. This is just an example of what might happen with a heart surgery, and you'll hear a lot about this later on this morning. If you go back here, if this is torn, one of the things that can be done is these leaflets or these cords here can be sometimes resuspended or reattached. That sometimes can be done. But sometimes, rather than trying to repair the cords, what will be done is the valve itself will try to be cinched in or belted in so that it doesn't leak anymore. You know, if you've got a door jamb that's too big for the door, you bring the door jamb in some, the door won't leak as much. Well, one thought is, well, if you've got a leaky valve, if you can bring the door jamb of the valve or the surrounding surface of the valve in some, it won't leak as much, especially if you can remove the damaged portion of the valve. This just shows one technique where a portion of the valve is cut out and removed. It's sewn together. Again, this is that horseshoe portion of the mitral valve. And then a supporting ring is put around the outside of this. And you've heard probably a fair amount if you've read any of the symposium articles that get published in the Missoulian about Carlos Duran and the Duran ring. This is one example of what we call a ring, or a supporting structure that's put around the valve to basically support it so that it doesn't leak as much. They can remove the offending, damaged portion of the valve and then support the valve with this ring around it so that it doesn't leak. Now, not only can they fix valves, but we sometimes and will replace valves as well. One of the replacement techniques is replacing it with a tissue valve. Sometimes we can replace it with a metal valve. So there's a lot of different kinds of valves that can be put in play. Well, I'm going a little long here, but what I was really asked to do is comment, how do you know you've got a valve problem? Well, the right answer is, most of the time, you're not going to know. What will happen is you might have some symptoms, or, not uncommonly, your doctor will hear a heart murmur in the office. Now, heart murmurs in and of themselves don't imply a problem. Heart murmur is a sound. It's if that sound is associated with a valve problem that we might get potentially concerned. But there are a number of types of symptoms. They're fairly nonspecific. I mean, there's a lot of things that can cause people to have trouble with breathing. There's a lot of things that can cause pressure sensations in your chest. There's a lot of things that can cause your heart to flip, skip, jump, and flop. But occasionally, these conditions are going to be associated with a valvular condition that might need some kind of medical treatment or surgical treatment. Realistically, the way you can find out if you've got a heart valve problem is by somebody taking a listen to you and then somebody taking a look at your heart valve. And the way we nowadays look at heart valves predominantly is with a technique called echocardiography. And that's the segue into the next talk, which is by our newest partner and colleague, Dr. Rich Gula. And Dr. Gula is recently arrived from North Carolina, where he was affiliated with the program at Duke University. He also is what we call a non-interventional cardiologist, meaning that we generally don't pick on people too much other than in the office. And he's going to talk to you a fair amount about what hearts look like and what valves look like with some of the imaging technologies that we use with ultrasound.
So this is who I am. I'm Rich Gula. I'm a non-invasive cardiologist. My job is to diagnose what the problem is. Where Joe left off, how do I know that I have a valve problem? That's where Joe and I come in. Joe and I are the linemen of a football team. It's our job to create the hole for the superstar to run through and, be the hero. So Joe and I are in the trenches, and people like Stan and Dr. Tada and Dr. Maxwell, those guys are the superstars. By the way, they're passing out a little paper here for everybody, and it'll also be out there, and it tells about cardiac ultrasound or echocardiography, which is a very nice technique that we use using sound waves to determine what's going on. Now, Joe mentioned that we are nothing more than plumbers and carpenters. And he's right. That's what we do. So if you come to me and I hear a murmur, I just turn the valves and let the blood flow go through easier. And we do that initially through medical therapy. But there does come a point where medical therapy is no longer useful or valuable. And the nice thing about heart valve problems is that generally they don't just suddenly start. They generally are something that brew over the course of time. And so just like these valves, you can see the pipe's a little rusty and maybe the valve doesn't look like it's very new. Well, that's a valve that it's taken time to get rusty and to build up junk on the inside so that the flow doesn't occur so easily. I think you saw this picture before. There's 4 sets of valves, 2 on the right, 2 on the left. Joe went through all that anatomy. We won't be concerned with what happens on the right because that's a low flow state. Those valves do get into trouble, but they don't get into trouble near as much as the valves on the left side. There's 2 kinds of problems with those valves. One is that the valve is too stiff. The other is that the valve is leaky. So what I like to show my patients when I talk about their valves is I take my hands, and this being Montana, a hinge gate is something that's familiar to everybody, like in the corral or just a simple swinging gate. So when the valve opens, when the heart pumps, the valve opens. Blood flows through very nicely. And then when the heart relaxes, the pressure from the valve comes back down and closes that valve. So under normal circumstances, that valve opens and closes without any difficulty. But when the valves start to go awry, they may become stenotic or stiff, and that valve doesn't open as much. And over the course of time, it opens less and less until it becomes a problem. Almost invariably, if you have a stiff valve, you have a leaky valve. Because you can imagine if this valve that was opening so nicely with 3-in-1 oil when you were younger, when it closes, it can't come together as nicely as it was when God put it in our body. So you develop the stiffness, and you also develop the leak. Well, does that mean that every valve is stiff and leaky? No. Most of the time, the leaky valve is the problem. The stiff valve is a problem, but it's not as common. The arrows also indicate the direction of blood flow. So the heart, the blood comes in from the lungs, goes to the left atrium. It's oxygenated, It's ready to go out to the body, supply the body with nutrients, goes passively through the mitral valve here on the left side, flows into the left ventricle. The left ventricle, then the timing mechanism makes it squeeze. When it squeezes, you can imagine the pressure of the valve of the blood pushes back on the mitral valve closes shut, and the blood passes out nicely through the aortic valve. So that's the way it's supposed to happen. And this is just another cartoon as we see that the main arrows just basically show you the direction of blood flow and how simple that pump works. It's a very simple process. And that's, I guess, too big for this. But this is a more real picture of what the heart looks like, complete with the muscles and all this. These are the papillary muscles and the chordae that attach to the mitral valve. And you can see in the aortic position, those are not there. So the last part of Joe's talk, he was talking about if these things break or they stretch, they can create a problem with leakage in the mitral valve. The aortic valve doesn't rely on those, but if the valve doesn't come together right, you get the leaky valve on that side. Now, cardiac echo or cardiac ultrasound or echocardiography is nothing more than the same ultrasound that they use on pregnant women to look at babies. It's exactly the same. But because we're cardiologists, we have to have our own name, so we call it echocardiography. That way we won't be confused with a gynecologist. Just in case you were worried about that. And all we basically do is put this probe on the chest, the horizontal box on the top is the probe. The dotted line is your chest wall. We put that probe on your chest wall. We move it around. It sends sound waves. Thank you. It sends sound waves through the chest. This is the sound wave as it comes through. And below the sound wave, what happens is the sound wave comes through, it bounces off the wall of the heart, goes deeper, bounces off the wall of the heart, goes deeper, bounces off the valve, goes deeper, bounces off another valve, goes deeper, bounces off the back wall of the heart, and then finally into the lung area. And all of those sound waves come back through the miracle of technology, are reconstructed, and they give us a picture of an echocardiogram. This is one picture from my talk. Unfortunately, that didn't work. But if you look, it's on both sides, it's the same. This is the sound wave that we're talking about. Now, as Joe said, because we like to confuse people, because if we told you all our secrets, then you wouldn't have to come to us. So we turn this upside down and backwards, and we can look at it, but you guys don't have a clue what you're looking at. But it's kind of cool, And so as the sound wave comes through, this one's similar to this one. It comes through, and you can see that it bounces off the walls. You can see the valves. You can see the back wall of the heart. And this was supposed to be in moving action. So you would have seen the valves. That's really what you needed today, was to be able to see that. You would have seen the valves open and close, and you would see how this set of valves open and closes opposite of those set of valves. So the whole timing cycle would have made sense with regards to what we're talking about. So I apologize to you that didn't work out. But because of sound wave, we can look at all of this stuff. We can tell whether your valve is significantly abnormal or if it's just a sound, something we don't have to worry about. Now, I would be willing to guess that of all the people in this room, I would say probably 90 or 95% of you have some kind of murmur. The good news is that 85 to 90% of you, the murmur is completely normal. Or I shouldn't say normal, but it's benign. It's not something you have to worry about. So a lot of times you'll go into your primary care doctor, they'll hear a murmur. The doctor will say, let's get the heart doctors to check this out. Or let's send you for an echocardiogram and see what it shows, and then we'll kind of go from there. So that's how all of this happens. There's other ways that we pick up murmurs, and that's people get short of breath, they develop cough, they fatigue easily. All of these are symptoms of valvular abnormalities. And if you take the heart and we cut it this way with a sound wave, we get this picture where we can look down on the valve. And again, that's the aortic valve, pulmonic valve, that's on the right side, the mitral valve, and the tricuspid. The mitral and the tricuspid are the two valves that give us the most serious problems. This is just a cutaway view of the same thing, similar to what Joe showed. This is a valve that is real stiff. It's an aortic valve. It's real stiff. It doesn't open well. And because it's stiff and it doesn't open well, it also doesn't close well. So you actually have two murmurs built into one with that particular one. This is a surgically corrected disease. Some of the other problems where you have a leaky valve, what we do is we treat those medically to let the heart work easier, take the pressure from the inside of the heart, reduce it, and that helps the valve to work easier. It's our job to keep an eye on that on a regular basis to make sure that your chamber, your pumping chamber, doesn't get weak. If it starts to show signs of weakness, then it's our job to get you to the superstar, the surgeon, or we have new technology coming in that we can do through the legs, percutaneously, to do something to those valves. But regardless, when it gets to that point, it needs some kind of surgical intervention. This is nothing more than an echo that I tried to put on an overhead so that you could see it. This is that problem with the mitral valve. This is the most common valvular abnormality that we have. It's very common in young people. You can see that the valve goes up like a parachute. So the heart pumps, the blood's supposed to go this way, but because of the weakness in this valve, it's too long, it's too elastic, it's too floppy, the blood goes back. The blood always goes to the path of least resistance. So this is generally the path of least resistance, but if you have lots of pressure in there, most of the blood's going to go this way, but some of the blood is going to go back that way, and that creates that leaky valve going back up into the heart. If your valves are bad enough, if you don't seek medical attention, you end up like this. This is a guy who has to sit up because he can't breathe. The blood is backing up. It's backing up into his lungs. It's backing up into his legs. He's going into congestive heart failure. We can treat that, but a mistake that's frequently made is you treat the heart failure and you don't look for the reason. And many times the valve is the reason. We don't make that mistake here. One of the reasons I came here is because this is a first-class heart facility. And I'm very proud of my association here, and I'm very thankful that they allowed me to come and work with all you guys. But this is what we do, and this is what we take care of. And this is fluid in the lungs. This is the heart. We want to prevent this. Now, sometimes the situation is so bad, or it's so late, and you all know that men are not necessarily the best patients. And they have a tendency to say, oh, it'll be okay, you know, and then 3 months, 6 months go by, and by the time that person, usually a guy, unfortunately, gets into our office, he looks like that guy. And it's past the point of repair. But fortunately, we are able to unload the heart, make it work easier. We're able to watch the heart closely. We watch for the signs where the correct timing is right to get that patient to the surgeon or to our interventional partners so that they can work on that valve and correct it. Now, again, I apologize for not having all the bells and whistles with my talk, but I appreciate you all being patient and listening. I don't think anybody left, so that was a good thing. And I appreciate it. Thanks.
Our next speaker is going to be Dr. Stuart Long. And Stu is pretty new to us. He's been here just a few months. He comes from Emory. He's a bright, young heart surgeon. Seems very young to me. He's a superb clinician and a very nice person, and we're delighted to have him as a part of our team. So welcome, Stuart Long.
Good morning. Thank you, Stan.
Oh, there you are.
I slid in behind you.
I was looking for you to come from over here. I'll shake your hand.
All right. Today's topic is kind of about the ups and downs of cardiac surgery, and it's a little bit of a difficult topic to talk about. We like to focus on the positives, but obviously there are some negatives and potential difficult times afterwards as well. So what I'll do is kind of run through kind of what to expect if, should you have heart surgery, and some of the folks in the audience I'm sure have had heart surgery and can correct me if I'm wrong. Also, we'll talk about some of the downtimes that can happen in the recovery period and what to look for if yourself or a family member should have those, and how to seek help and where to seek it. Should you have some depressed mood after heart surgery, which is fairly common at times. The basic ups of cardiac surgery for coronary disease, if you have bypass, are basically you live longer, so improved survival, increased freedom from angina or the chest pain, and increased freedom from future heart attacks. So those are the main benefits you get from heart surgery. Should your disease be severe enough to warrant heart surgery instead of medical therapy or stent therapy. For heart valve surgery, replacing a valve, either with a mechanical valve or a pig valve, or repairing the valve, the benefits again are improved long-term survival, living longer, and improved functional capacity, so freedom from heart failure, breathing better, exercising better. So what should you expect should you happen to come to needing heart surgery? And heart surgery is very common. The United States, coronary artery bypass is one of the most common procedures performed in all of America. So expect to come in the day before surgery, have some blood work drawn, kind of reevaluated.
If he doesn't, we'll do without.
The day of surgery, most of the time you'll come in pretty early, a couple hours before your scheduled start time. The surgeon will normally come speak to you again, answer any last-minute questions. The surgery itself is roughly, most heart operations, anywhere from 4 to 6 hours on average time. So it's a pretty full day, or half a day worth of work for us. After surgery, you're taken up to the intensive care unit. You'll awaken several hours later with the breathing tube in your mouth. You'll have tubes coming out of your chest that drain fluid, and you'll have some wires coming out as well. The wires are, in case we need to make your heart rate go a little faster than it wants to go, or also to monitor the heart rate and your heart rhythm. You'll have some bandages on your chest for any kind of heart surgery. Also on your legs if you have bypass surgery, because the most common, what we call conduit, used for bypass is the leg vein. Also sometimes we take an artery out of one of the arms. You should feel pretty sore, but probably not have severe pain. If you're having severe pain, you'll communicate with your nurse, and we'll give you pain medicine. And the pain gets better over time. Other commonly asked question is, when can my family visit? Roughly, your surgeon will talk to your family immediately after the heart surgery is over. Let them know that you're doing fine and everything went very well. Your family can come visit you approximately 45 minutes to an hour after you get to the intensive care unit. The main reason is that we basically just need to do some working. The nurses in the intensive care unit need to kind of get you settled down and kind of get some of their work done to get the monitors hooked up and make sure everything's looking pretty stable. Then your family can come in and visit with you for a period of time. The later visits are kind of arranged individually with the nurse. We have a fairly open policy allowing you to come into the intensive care unit. Obviously, there are other patients getting taken care of, and most of the time that would limit your family's access to you while you're in the intensive care unit is maybe something's going on with another patient that we have to respect their privacy as well. What to expect for the rest of the stay? Most folks have the breathing tube removed the same day or the night of surgery. We'd like to do that as soon as possible, often as early as just a couple hours after the heart surgery is over. Most folks just spend one night in the intensive care unit and then are ready to go up to the regular floor or ward on a monitor. Majority of patients, we can take out the drainage tubes from their chest, and that makes it a lot more comfortable to take some deep breaths. And we also very commonly remove some monitoring lines the next day of surgery. Commonly you have a monitoring line in the neck that measures the heart function, how much basically blood the heart's pumping out, which is obviously an important number for you and the surgeon to keep track of immediately after surgery. What should you expect once you're out of the intensive care unit up on the regular floor? You should expect to get out of bed and start walking and start acting normal again. And so you'll hear your surgeons tell you to walk, walk, walk. That's one of the best things you can do. It helps get the lungs fully expanded. You were kind of designed to be upright. And when we're laying down flat in bed, the blood flow and the kind of goes to the bottom part of the lungs, and the lungs don't fully expand. And particularly after a fairly long operation, the lungs aren't fully expanded. So this helps prevent pneumonia, get you up walking, moving around, and just kind of generally feeling better the more you get out of bed. We'll have you do breathing exercises, and we'll have some difficulty or a little bit of pain while you cough. So we have a special pillow that's shaped as a heart. You can hold it and squeeze it, and that stabilizes the breastbone while you cough. So coughing and deep breathing are very important. Almost everyone gets a regular diet the next day, usually low sodium. It's extremely common for people to experience some nausea and may have a little bit of loss of appetite immediately after surgery. This is normally related to the just being under anesthetics, and this goes away with time. We try different medicines, but usually the best medicine is just tincture of time, letting a few days go by and it'll go away. Commonly, the bandages are removed around the second day after surgery. More details about hospital recovery. To do heart surgery, we put you on the heart-lung machine for majority of operations, almost all of them. And by doing so, we have to give your body extra fluids to kind of maintain you on the machine. So immediately after surgery, your body's in a state of kind of having too much fluid in its tissues. Particularly the lungs, so that requires almost everyone to be on oxygen for a period of time after surgery through the nose. So expect that to be on for several days. We'll be giving you medicine. A very common one is called Lasix. Many of you may be on this drug before surgery or after surgery, and that helps you to urinate the extra fluid off. Expect to feel better and a little bit stronger every day. It's very normal to get tired out easily and have some emotional swings up and down. Part of this is kind of being confronted with a major operation, kind of a life-threatening problem you've just dealt with, and kind of reality check that we're all mortal. The other common questions is, when can you go home after heart surgery? The basic requirements is that you're off oxygen, you're up walking, you're eating a regular diet, you have a stable heart rhythm, and then should you happen to have a mitral valve or a mechanical valve or be an irregular heart rhythm, your blood must be thinned out to appropriate levels where we feel it's safe for you to go home. The most common drug that we thin the blood out with is called Coumadin. What should you do after you go home? You should basically try to get back to normal. Try to have a normal sleeping routine, a normal eating routine. Get up in the morning, get showered, get dressed, kind of take on the day. It's very common for patients to need a nap kind of mid-morning, or a rest in the mid-morning and a nap in the afternoon. Other things to do are to take a short walk, ride a stationary bicycle. Essentially try to tire yourself out through the day by waking up appropriate time, staying pretty active, and your goal is to be pleasantly tired by the end of the day so you get a good night's sleep. It's very common for the sleep-wake cycle to be disturbed after major operation, particularly heart surgery, and it's also after a period of time staying in the intensive care unit where the lights are on all the time, a lot of noise, so it gets people kind of out of whack with their circadian rhythms. Other ideas are to take some pain medicine, particularly within the first 3 weeks after surgery. Your body's recovering from basically a major operation, a major event. Healing the wounds in the incisions takes a lot of protein and energy. So it takes about 3 weeks to where you really start kind of picking up your energy. After the 3 to 6 weeks, you'll feel better, have more strength, pretty much daily. Another recommendation is take your temperature for the first couple of weeks, a couple times a day, just to make sure you're not having a fever, some things your doctor would want to know about. And let us know if you have a temperature above 100 degrees. You can weigh yourself every day and expect you to have some weight loss for the first several weeks. This is due to the fact that you're kind of healing and using a lot of your protein stores. Another thing to watch and important to weigh yourself is to make sure you're not gaining weight too quickly, particularly water weight. If you start gaining more than 5 pounds, it could be extra water, and we may need to adjust your medicines. Some folks after heart surgery need to stay on what we call diuretic medicines like Lasix to keep your fluid balance appropriate. If you start gaining weight, we'll want to know about this, either your heart surgeon or your cardiologist. We may want to adjust your medicines. Another commonly asked question is what you should not do after heart surgery. You basically cannot drive until you're strong enough to kind of hold the wheel and turn out of the way of a young child that may run in front of you and hit the brakes, and while you're off pain medicine. Normally, we restrict your driving till you see us back in the first follow-up visit, which is roughly 3 or 4 weeks. We also ask that you not push, pull, or lift anything weighing more than 10 pounds for around 6 to 8 weeks. This allows the breastbone to heal. The most commonly approach to the heart, which sits right behind the breastbone, is through the front, and we put the breastbone back together with some wires, and this takes almost 2 months to fully heal up. The general rule of thumb is you don't want to lift or carry much more than a milk jug. Now for the downer part of the talk. There are some downs that come after heart surgery. It's very common for people to feel sad or depressed. These emotions may be the result of not knowing what to expect in the future, just some general anxiety, not being able to do simple tasks around the house that you could easily do before without becoming overly tired. One thing to note is just as in a normal daily life, temporary periods of sadness are fairly normal and can expect to get better on their own. They should gradually go away within a few weeks after your heart surgery, particularly as you get back to your normal routine of your daily activities. If your mood stays severely depressed or it's accompanied by other symptoms, which I'll describe, that persist every day for a period of 2 or 3 weeks, treatment is probably necessary. Depression itself can intensify the pain after heart surgery. It can cause worsening fatigue and sluggishness. It can cause a patient or a family member to withdraw to social isolation. And interestingly, people that have depression that's untreated after heart surgery have an increased late mortality after surgery. The other symptoms I alluded to, in addition to a depressed mood, the patient or family member may withdraw from activities that they normally engaged in. They may not respond when they're being visited by family or friends. They have a lot of negative thoughts, kind of unexplained tearfulness. Also, occasionally, less commonly, are potential for suicidal thoughts or feelings. If these are happening, this is a kind of major red flag, and that a sign of very severe depression, that that the patient or you or your family member needs to seek help immediately. You can call your family doc, your heart surgeon, your cardiologist, or just come to the emergency room because this needs to be addressed and dealt with. So the other causes to seek help sooner, these negative feelings persist every day for 2 weeks. If you notice you're having difficulty just getting through your daily routine, difficulty with your usual social activities, difficulty back at work, or if you just realize what you're thinking, you're not sure if it makes sense or you know it doesn't make sense, you need to kind of seek help. Some things to help deal with the difficult mood or the downswings after heart surgery. As I stated before, get dressed every day. There's some stress management and relaxation techniques that your physicians can go over with you. Get out and walk every day. Exercise is an excellent treatment to get folks kind of back on track mentally as well as physically and re-engaged in their normal daily activities after a major operation. Cardiac rehab is another great way to get your exercise. Also gives you a peer group of folks who have gone through the same thing you've gone through, people to sympathize with, people to talk to, people at kind of different stages in the recovery period. And it's very beneficial. Other tips for coping with the depressed mood or the downswing moods, again, are kind of get back in the hobbies you enjoyed. Get back into social activities. Let other folks know what you're feeling or going through. Share your feelings with your spouse, friend, clergy member, someone you can trust. Again, try to get a good night's sleep. Again, exercise during the day, taking a pain pill at night may help you get back to sleep on a regular basis. Eat a well-balanced, nutritious meal, and ask your doctor about the support groups. A couple things to avoid. It's very common when we get depressed or down mood to kind of slip back into the old crutches, the old habits. Pick that cigarettes back up again because they always made you feel good, or hit the refrigerator, a little overeating, piece of cake, kind of get the transient, satisfaction, or drugs or alcohol. These are things to avoid. All these things are negative impact on your long-term health, your long-term recovery from heart surgery, and your just general state of well-being. The folks that have serious clinical depression after heart surgery, just like anyone that's depressed, whether they've had heart surgery or not, need to seek treatment. Some of the common treatments, most commonly is an antidepressant drug. You may have heard of Prozac or Zoloft or some other common drugs that are very effective, more so today than in years past. Psychotherapy can be done independently of the medicines or combined with the medicines to help folks get through a period of depression. And then, as stated before, leading a healthy lifestyle, exercise, eating right, and kind of re-engaging back in life can help one overcome the symptoms of depression. So in conclude, the main goals of heart surgery are to help you live longer and help give you a better quality of life. And so that's what we're all about. And there's some downswings that can come after heart surgery, but majority of folks do very well, are in the hospital 4 to 5 days, and can re-engage in life pretty quickly after they get home. Sometimes it does take a couple months to get the breastbone to heal up, get you back full activity, and then even a little bit of time after that so you really feel like you're back on the upswing. Many folks, particularly that have had ongoing chest pain or angina, feel amazingly better even within the hospital stay. Their shortness of breath is relieved, chest pain's relieved. They have some sternal pain discomfort, but it's a different type of pain, and they're much better off. Their exercise capacity, even in the hospital stay, is improved since before the surgery. Again, with heart valve surgery, many folks are limited to exercising, difficulty breathing, and again, immediately after heart surgery can walk and have a tremendous increase in functional capacity even that first week after heart surgery. So as with anything in life, there's some risk to be taken, but there's a lot of benefits to heart surgery. And as I was talking to my partners the other day, for each individual patient, undergoing a heart operation is probably the most risky thing you'll ever do in your whole life. Statistically, it's safer than it ever has been since the advent of the heart-lung machine in the 1950s. But for you, it is a risky time, so you have to kind of understand the risk, but there are major benefits to you.